distant, painful nightmare. But maybe not. Maybe you'll come to love it, enjoy it like I did. With neuro, I think with everything, but with neuro, it's even more important because with neuro is very difficult to learn. Think about the anatomy of neuro compared to the anatomy of muscles. Muscles you can see, they are demarcations. You can see this is a muscle, that's a muscle, they're different. What does the brain look like? Just jelly. And this off-white jelly next to that kind of grayish jelly, those are different structures. They do completely different things. It's really hard to see with your eyes. And so you have to understand it. Now, neuro is also so complex that if you don't understand it, then you're punished even more than you would be with other parts of anatomy. And so we're going to start with that. We're going to start with the understanding and particularly the organization. Because if you can organize the material that's going to be entering your brain, you're going to pull it out a lot better, and you'll be able to understand it. And then we'll do this fairly quickly. And then I do want to open it to questions or certain topics you want me to cover. I think covering the spinal cord is really important, and the tracts and the laminae, that can be really important for later on. It looks like up through midterm you cover what, through the brainstem? Is that what it was for the midterm?
Yeah.
Okay. Okay, nervous system. We have structure. Let's do structure on this side since everyone's up there. We have structure and function. Structure and function. And you'll hear like DOs will say, what? Structure dictates function. And so that's why the idea of moving bones back into place is that if the structure is healthier, then the function will be better too. Okay, what are two types of neural functions? What are the two kind of basic directions? Motor and sensory, thank you. So motor, also called efferents. And in the spinal cord, it's called
Dorsal.
Descending.
Okay.
So that's information going out from the brain. And then we have sensory, which is information going into the brain. So afferent or ascending. You can take pictures of this stuff later too if you want. Switch colors. Okay, motor. We have somatic and visceral types. And so we're going to be using these terms because have you heard of GSA, GSE, all those kind of three-letter designations? Okay, well, we're using these terms because by the end, you'll be able to know all of those three-letter designations just by drawing this up. It becomes very easy. The way I learned was conscious and unconscious motor. So somatic is, it's not exactly accurate to call it that, but it's close enough. So you can say somatic is conscious, that's going to our skeletal muscles, and then visceral is going to smooth muscle, and so that's unconscious. But there are some somatic reflex pathways that aren't quite conscious. So I like somatic and visceral. And then the other part of the designation is whether it's general or special. For somatic, we have just a general branch. And the most, the one that you want to know the most, actually we'll get to that in just a moment. But visceral, we have also general. And we also have special. Now the idea is, once we get this down, you can put all the pathways that you're learning, organize it here, because each category will come with certain key features that all of those pathways have. And so when you group things this way, you'll get more understanding out of it. We're gonna go through this kind of quickly. Don't expect things to make sense for the first 45 minutes. We're just gonna run through it, okay? General, so GVE, do you know what this is? General visceral efferent. It's motor going out to the viscera. Do you know what that's also called? Autonomic nervous system. Sympathetic, fight or flight. Parasympathetic, rest or digest. That is right here. All of it's right here. It's motor to the viscera. So this is your ANS, and you know that there are two branches. These are equivalent. Sympathetic and parasympathetic. General somatic, you have a lot of different pathways, but the most important, what do you think is the most important somatic motor pathway? Or if you can GSE. Yep, so this will be GSE. Do you have any other titles of these pathways? You may not have covered it now that I think about it, but you must have seen it at some point. Corticospinal.
Oh, yeah, spinal thalamic, stuff like that.
Those is a little bit different, but part of the spinal cord. Okay, so you can call them pyramidal pathways. They start in the pyramidal cells of the brain, decussate in the pyramids of the medulla. So pyramidal pathways, you have two of them. Already running out of space, corticospinal and corticobulbar. Anyone know the difference?
Where it's going.
Body, face. Bulbar goes to face. That's a level of organization you're gonna see. You have organization, motor, sensory, front and back, left and right. We also have body, face. So corticospinal is body, and bulbar is face. Sometimes they call corticobulbar corticonuclear because of the cranial nuclei that send that motor information. Okay, that leaves one more, SVE. This is a tough one. This is actually probably one of the least important categories that I tend to kind of merge with GSD, but anyone know what SVE has to do with? Do you remember your branchial or pharyngeal arches?
Yeah. Mm-hmm.
Our gills. Anything that goes to our gills is considered SVE, is motor. So what's going to our gills? V3 for mastication. 7 for facial expression. Some 9 and 10 for some like palate and throat stuff. So those are all part of, those are SVE functions. Anything going to the pharyngeal arches. Just as a very quick recap, you have 6 arches, the 5th disappears completely. Each one beyond that has its own nerve that goes to that arch. So you study the arch to the nerve. I'm pretty sure this is first arch, second arch, and then we have 3 others, because again, we'll put those away. Now, does this have to do with motor coming from the throat or from the palate? Does this include motor coming from the palate to the brain to let you know that something's there? Why or why not? So this is the organization that leads to the understanding. Why not? Yeah, it's efferent. We're in efferent. This is efferent. Motor has to be going out. So you have to separate those. There's sometimes where GFE or autonomic nervous system will share pathways with other sensory pathways, different pathways, you have to keep them separate. Just like, you know, there may be you and the person driving next to you on the same road, but you're going to different places. You can share the road, but not have the same destination. All right, this is all of motor, basically. There's a lot of different types of pathways that we haven't quite included, but a lot of those are kind of reflex pathways. And what's cool about the pathways, have you noticed what the names do?
Tell you where it's going.
Yeah, where it starts, where it's going. So anything that's blank spinal, what type of pathway is it? Blank spinal means it's ending up in the spinal cord and then going out to the body. So it's all motor. Anything that's spinothalamic, spinal blank, is going to be ascending. So for a lot of these pathways, the name is just going to tell you where they're starting, where they're going, whether it's afferent or efferent. Okay, let's move on to, I have to move this around a little bit, but let's move on to sensory. Okay, sensory is very similar, but instead of separating into somatic visceral, I'll start with general and special. Next we'll organize into somatic and visceral. But with these, I feel like it's easier to start with this organization. Okay, general sensory can be, what are our two options here? You'll have to come up with this on your own, so. Yeah, visceral and somatic, same ones. Visceral, you don't even have to, you don't have to worry about that one. Those are all, they often will follow autonomic fibers. So they'll often hitch a ride with these, go in the opposite direction. But you're not going to be tested on these. But think about like referral patterns. If you have pain, heart pain, gallbladder pain, how there's certain referral patterns that it has to do with those fibers and where they enter the spinal cord. But you don't need to know those pathways, so just don't even worry about them. General somatic afferent, so GSA, what is that?
From the skeletal muscles to the brain?
Close, yeah, so some of it's from the muscles, like from the spindle cells or Golgi tendon cells for proprioception. Do you know that the big picture name of this somatosensory? Does that ring a bell? It's very important. So these are your somatosensory pathways. This is your touch sense. But our touch sense is actually at least 5 senses wrapped up into one. This, just like motor, somatic motor, is organized body and face. So we have body and face pathways. These are very important. We can cover these if you'd like. Because there's some simple tricks to learning them. Special, what are our two options? It's real somatic. If you're answering neuro questions in a bored tone, that's a good sign. That means it's making sense. And that seems too simple. Visceral, so this sometimes is more difficult to understand, but I think of visceral, what are the things most relevant to digestion? Because I think of viscera, like a lot of digestive organs, what's most relevant to digestion, okay, or food, let's say. Taste should be one, right? So gustatory. And what's the other one that's really linked to taste? Olfactory. The rest are somatic. Eyes and ears are somatic. So eyes, visual, ears, cochlear, auditory, vestibular balance. And so this is SVA. This is SSA. So for each pathway you learn, you want to ask which one is it, what's the category, and that will help you understand it. That will give you some understanding. And these are, for neuro, I mean, this could be a pretty good board question. I mean, this is the type of board question I would ask. What type of, what type of information is carried in the visual pathway? SVA, SSA, GVE, because if you understand that, if you know that, either you memorize it, which is unlikely by the end of year 2 that you still remember that, or you understand it, you know, whether it's afferent or efferent, somatic or visceral, etc. So if you should be able to get to this point fairly quickly. By the end of the day, you should be relatively comfortable with this, and then you do spaced repetition, study again tomorrow, study at the end of the weekend, and you should be relatively comfortable with this. All right, any questions so far? The structure should make, that part should be easy. So for structure, what are the two parts of the nervous system? By
CNS.
CNS and VNS? Based on names, you'll often know which one you're in. PNS, these are nerves. They're also ganglia. These are more tracts and nuclei. All of your named nerves from the first couple quarters, it's all PNS. This is important when you start learning about neurological pathologies. And so if someone has a motor issues, they have paralysis, you don't know whether it's coming from the peripheral nervous system or the central nervous system unless you know what type of paralysis and how it presents. Because not all paralysis is the same. You may have heard of flaccid paralysis and rigid paralysis. Well, what's the term for it? That's not the term.
Contractile?
Spastic.
Spastic, thank you. And again, this is where the organization comes in, because especially with neurological things, it's if you can understand the underworkings, you'll be able to identify where it is, how it's affecting things. Okay, CNS, obviously, all right, we got the, that's one of it, so we can do cerebrum. Sometimes this includes, let's say, lobes, and then the deep nuclei. Diencephalon. Hopefully you can list a few things that are there. Thalamus, epithalamus, hypothalamus, pituitary. Neil's in there too, I think.
Mm.
We have brainstem, we have cerebellum, and then spinal cord. This is how I studied, actually, just drawing stuff out like this. Just making sure I knew what things were and how they really fit with things.
What's the epithalamus?
It doesn't do much. I think it does like one or two things. I'm trying to think of what it does, but I think also subthalamus is in there. Or maybe it's subthalamus and not epithalamus, I'm pretty sure it's the thalamus. It's not that. So, that's another thing, keep me honest, I do these things just from the habit, so just make sure and check it too. Okay, any questions? This is the overall organization of the structure and function. When it comes to the pathways, make sure you organize the pathways. It's like when you go shopping. You don't go home from, get home from Sprouts and just stick the bag in the closet and deal with it later, do you? Let all your alternative milks, plant milks go bad and stuff like that? No, you put it in the fridge, you put it where it belongs, right? That's how we shop. So the same thing with the knowledge. As you're learning, you gotta put it somewhere. And always put it back to where it belongs in the organization. It's gonna make more sense. Or I mean, if you stick it in the closet now, you'll have a mess on your hand later.
Or now. Oh no.
All right, what next? Or is there anything we can talk about?
No.
This is kind of important, actually.
It's not important. Not as important as our neuro and
For sure you can do it. I can read it in there.
All right, I'm not responsible for this then.
Yeah, I will.
Nothing's as important right now.
Okay, do we want to go over spinal cord organization? Spinal cord organization, I will say, is very important. If you want to do anything pain related, I don't care if you want to do prolo, go for it. But if you don't understand how the spinal cord works and how pain works, you can't be a good doctor, even if you have the best tools. So we can go over that. There's my block. Or if there are any objections or alternatives, I'm open to them now.
That's good.
Okay, let's do it.
Dr. Claude, do you know what subjects he's testing us on already? So far?
What he has so far?
Yeah.
I don't, but I saw the syllabus and it looks like you're at least through spinal cord.
Mhm.
And it looks like you'll be up through brainstem.
Right.
Is that correct?
Yeah.
I was just making sure you had the syllabus or whatnot.
You're the
Yeah, I looked at it, I didn't remember to review it before I came here today though.
You think so?
Okay, so we have our
No, it's part of it.
cross section of our spinal cord. This is dorsal, this is ventral.
Because brainstem's way lower.
Okay, what's this? It's not a tumor, right? What is that?
Ganglion.
It's a dorsal root ganglion.
Mm-hmm.
Ganglion, what's a ganglion?
Cluster of cell
Yeah,
bodies.
let's actually cover that real quickly. Soma, or the cell body, versus the axon. Injuries to axons and cell bodies will behave differently. And so you want to know whether that structure that was damaged was an axon, bundle of axons, or a bunch of cell bodies.
This is way more interesting than anything.
Okay. So we have ganglia, or ganglion, or cell bodies in the PNS, or in the CNS, we have nucleus. We have an exception though. The basal ganglia, as they're often called, are actually in the central nervous system. It's a misnomer. Sometimes they're called the basal nuclei, which is more accurate, but less used. Axons in the PNS, these are just your nerves. And then the CNS, there are tracts. So this is something, I always had this on the first test when I taught neuro. This was always a question to make sure you could identify them. I would tell them it was going to be questioned, 100% would be a question, and still usually 80% of people got it right. and 20% got it wrong. Just confusing and frustrating for me, but it happens. But this is important information. Why would I ask it on the first test? Because if you don't know the language, if you don't know what things are, you can't identify them, how are you supposed to learn it?
You don't.
Okay.
It's like jumping into tracks and not knowing what a track is.
Yeah.
So,
Do you know what a tract is now?
yeah,
Now.
sort of. Yeah.
Okay. Closer.
Thanks for
That's
that.
good enough.
Closer.
Just kidding.
All right, let's look more into organization, because this gets into another thing I would ask the first test, or right after we cover this, because it's important. We have roots or rootlets. Rootlets can be sometimes a better term, because sometimes nerve roots is overgeneralized to the whole thing, but technically it's just these first parts. And then after this where they kind of come together and then re-separate, these are called rami, or ramus. These are roots. What are these?
Bundles of
Branches.
oh.
Rami means branches. So they're roots and branches. Just like everything else in the nervous system, these are organized. Very carefully organized. And so based on where an injury could be, you'll know what deficiency will be there. Okay, roots are organized by function. So motor versus sensory. So these are your roots. And then the rami are organized by location. Front versus back. It makes sense to organize by function when you're near the central nervous system, but once you get out to the peripheral nervous system, it's got to go places. And so you got to make sure that the stuff that's going to your back is separate from the stuff that's going to your front, because they're going different directions. So roots are organized by function, rami by location. I'm going to test you on some mock injuries, and you can tell me where the symptoms would be, and we'll get progressively more specific about it too. So which way is sensory? So, okay, let's start with the roots. Which one of these, this is organized by function, so one's for motor, one's for sensory. Which one is sensory? The one in the back?
Dorsal. Dorsal.
Dorsal, because of the dorsal root ganglion, that's the sensory thing. And then therefore motor is going to be in the front. Motor is going to be going out, sensory is going to be coming in. We won't talk about what happens after that yet. Okay, now rami are organized by location. Do we have sensory coming from our back? If someone touches your back, can you feel it? Okay, so we do have. Now what about your front? Someone touches your front, can you feel it? So we'll have both. What about motor? Do you have muscles in the front and back of your body?
Mm-hmm.
Yeah. The back musculature, we'll get into that. It's a little more complex than the way I made it seem. But yes, we do have both ventral and dorsal branches of motor pathways. Any questions so far? Okay, so now what we do, which is the most fun part, is now we test it. We test certain lesions and how is this going to present? And so let's start very simple. Let's say we sever the dorsal root ganglion. What are going to be the symptoms of that?
Sensory.
Loss of sensation. Is it going to be front or back or both?
Both.
Both. Left or right or both?
Both.
Would be on the same side.
Right.
You said two different things. One of them was correct.
It could be on this side.
On the ipsilateral side, one side. So if this is the left-sided, ipsilateral. So left side, front and back. Yeah, okay, so those are the answers. And also the last thing is this going to be all the way down from this level or only at that level?
All the way down.
From everything below that level.
Only at that level.
Oh.
Because this is technically a peripheral nervous system injury. We're outside the spinal cord. If it was a spinal cord injury, everything below. But if it's just, this is just at one nerve root level, you get that one nerve root effect. If this happens at L4, you won't feel the L4 dermatome. If this happens at L2, you won't feel the L2 dermatome on the left side.
Ipsilateral.
Ipsilateral, exactly. One side ipsilateral for this type of injury. And only at that one level. And so I had a patient who's came in complaining of leg pain. When I asked her how it presented, so what's it feel like? She says, it wraps around my shin. As soon as she said that, I knew it wasn't coming from her leg, it was coming from her back. And then if I was gonna futz around with her leg and her knee, I was wasting my time and her time, and I wasn't gonna find the issue. The issue was in her back, because that's what the dermatomes do. They wrap around the shin. And so I went right to L4 and I pressed on it, and she almost jumped off the table because it was very painful. That's a good thing. That means that I found the issue. It wasn't, she didn't like it, but at the same time, we isolated, we found it. And so that's how, and she was fine by the time she left. But if I was trying to do stuff over there, I would have been, she wouldn't have gotten that relief because it was the wrong diagnosis. So this will help you not mistaken distal issues if they have central causes, or axial causes, I should say.
Can you explain the front and back thingy again?
Okay, we will get to that when we do this.
Okay.
And then that will make more sense. Let's do that now, why not? Let's cross off the dorsal ramus. Okay, let's say this is at, let's give a level. Let's start with L4, since we talked about that. That's a bad example, actually. Let's start with T4. Okay, dorsal ramus at T4 is severed. Okay, let's start with sensory. Am I gonna feel my back at the level of T4?
No. Nope.
No. Am I gonna feel my nipples, which is at the level of T4? Yes.
Yeah.
So I will feel the front, but I won't feel the back, because we only lost sensory to the back. Let's do motor. Will I lose innervation to the pecs? I forgot what T4 is, to be honest. But let's say there's a T4 innervation. I think that's a little way too low, but let's just say intercostals at T4. Am I gonna lose innervation to that? No, because those are in the front. What about, let's say, latissimus dorsi, which we're still too low for that, but let's pretend that T4 innervates latissimus dorsi. Would I lose innervation of that?
Yeah.
No, even though it's a back muscle. So we have to clarify back. We have superficial back muscles and deep back muscles. All those big back muscles are not, they're superficial back, so they come from the front. This is the most difficult thing to understand about this, but also very important. So back for motor is deep back, or they'll call them postural muscles. So call some out for me.
Like your rector spinae?
Rector spinae, multifidus, rotatories, right? The ILS is the rector spinae. So all those are gonna be deep back muscles, postural muscles that hold us up in the back. But when you have other back muscles like traps, lats, rhomboids, pretty sure rhomboids are part of them.
Yeah.
Well, they have, what's the innervation of rhomboids? I forgot. But yeah, so most of the muscles are going to actually come from ventral rami only the deep back postural ones, including some of the ones, or I think all of them in the suboccipital triangle. Pretty sure those are also deep back postural muscles. You'll often know because instead of a named nerve going to them, it's usually like, they'll just say dorsal rami of levels da 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 da. Dorsal rami, that's where we're at. If it's ventral rami, sometimes they'll say ventral rami, but usually it has its own name. Okay, so motor. Between dorsal ramus and ventral ramus, which is most likely answer of like muscles innervated by where does it travel through? Most likely ventral ramus. Pick a muscle in the body, call it out.
Bicep,
Biceps.
tricep, quads.
All right, so the rest are deep back.
Why is that differentiation the case? Just because deep back muscles are really important for.
So the ventral ramus, or the dorsal ramus is very tiny, and it usually does stuff right along the spinal cord at the back. Because even the sensory of the back, if we were to draw a person, if this was their back, so that's their spinal cord, the back sensory only goes a couple inches on either side. And so the lateral and the front comes from ventral. Interesting point is that this is also where urinary bladder goes, the meridian, 2 inches out. It got two places, but this is right where that differentiation between kind of ventral and dorsal rami from sensory, that's about right where the UB meridian is. Okay, so if I'm touching myself out here, is that sensory going through ventral or dorsal? Ventral. What if I'm a little bit in the back?
Also ventral.
What if I'm right in the middle of the back?
Dorsal.
Dorsal, exactly. So ventral is, the dorsal is small. It doesn't do as much. And so when we say front and back, we're pretty close, but yeah, that's kind of more specific. Does that make sense? One other thing is that everything to and from the limbs, with a very small exception in the back of the leg, goes through ventral rami. We can go over embryo to explain why, but I don't think it's that necessary. But everything for limbs comes from ventral rami.
Sensory and motor.
Sensory and motor. There's one minor exception, just a little bit of innervation on the lower butt and a little bit of the back of the thigh. But other than that, it's all ventral. So once we get to the legs, again, we get some kind of buttock part here, but the rest of the legs, front and back, it's all ventral. Okay, let's say we cut, let's cut the ventral ramus at C7. All right, sensory. Will the vertebral prominence area back here, will I be able to feel that?
Yeah.
No?
Yes.
You would, right?
Yeah.
So we still have the dorsal, which would be here, but we don't have the ventral. But what about the, where does C7 go, like in the hand area?
Oh, yeah.
Middle finger towards the back of the arm. Would I be able to feel the back of my arm? No, why not? Well, that's C7, it's still ventral because we're in the limb now. So even though it's the back of the arm, it's still considered the front when it comes to the nervous system. Okay? So especially when you get to the arms, you're talking about the anterior compartment and the posterior compartment. Don't mix those up with the rami, they're different. Compartments are locations within the limb. The rami is a nervous system organization. And with the limbs, it's all considered anterior or ventral rami. At C7, will traps work in the back if you get rid of No, because even though the traps are in the back, these are superficial back muscles.
Mm.
And so traps, lats, pecs at that level, everything's gonna be affected. You learned the brachial plexus, right?
Mm.
Is that ventral rami? Does that come from ventral rami or dorsal rami at those levels?
Ventral.
Why ventral? What's it innervating?
Oh, you're bent.
A lot of arm stuff, right? Yeah, it's all ventral rami. It's innervating the muscles of the limbs, and those are innervated by ventral rami, it's limbs.
And these are all ipsilateral that we've talked
Yep.
about.
Yeah, we're all on, we're looking at the body, you know, this will be kind of their left side, right? So this is all left sided, exactly. Okay, how are we feeling about that?
Awesome.
Okay, I feel confident you can get this one pretty well. Say we cross that off at L4. This actually kind of happened to my grandpa. It wasn't just that, but it was like the whole thing. So L4, we're gonna have loss of motor.
Mm-hmm.
And where would the motor be if it's L4?
Frontal leg.
They ever think of leg stuff? Do you know the myotome, the segmental motor for L4? It's a little bit, there's a,
Tib
That's
anterior.
sartorius, that's.
Tib
or
anterior.
That's 3.
which one?
Tib anterior.
Yeah, anterior tib, good. Sometimes anterior tib is given L5, just so you know, but we learn L4. And so my grandfather went in for surgery, they nicked the L4 nerve, and he had foot drop.
Mm.
Because tibialis anterior, that's gonna dorsiflex the foot, keep it up.
Mm-hmm.
Do you know how people walk when they have foot drop?
They drag their foot.
They drag it.
Well, yeah, well, if they drag their foot, they end up falling. And so what do they have to do?
Pick it up really hard.
They'll pick it up higher. But you'll see though that the toes are still pointing down. So with the toes pointing down, effectively, it almost makes the leg longer, so you have to pick it up more, so it doesn't drag. So we see someone picking up extra. There could be a few things, but that's a common one, foot drop. So at L4, yeah, tibialis anterior would be affected. Anterior compartment's the front of the leg, but it doesn't matter. It's all anterior rami. And but will you feel that part? Will you feel the L4 dermatome? Yeah. So you've heard me say dermatome, myotome, right?
Mm-hmm.
This will supply the dermatome, and this will supply the myotome. These were very confusing to me. I actually didn't learn about myotome until years later. These were very confusing terms for me when I was in your position. It took me years to finally understand them. I will try to explain them, but if you don't get it, understand that I was in your position, and sometimes it takes a long time to understand something. When we talk about dermatomes and myotomes, these are at segments. These are at levels of the body. You have it, well, you don't have a C1, you have C2, C3, C4, C5. So if you cut the nerve at that level, there's a specific part of the skin where you're not gonna feel, or where if it's a pain thing, where you'll feel pain. And if you can recognize those patterns, and you know this is a dermatomal distribution, you know not to be local, you're gonna go to the spinal cord at that level. And that's the important thing. Even though we have awesome medicine that's holistic, we still have to be able to understand what we're doing, otherwise it doesn't work as well. It only works if you know what you're doing and why you're doing it. The same thing happens with myotomes. And this, you'll see this with something like that, with the surgery. So it nicked L4, and so it affected that muscle. The rest of his muscles work fine. He can press down on the gas all day. Can't lift off though without picking his whole leg up, right? So the rest of the muscles are fine. This wasn't a top-down paralysis like if the spinal cord is injured. This is a peripheral thing. It's segmental myotomes. Another time you'll see this is with people that do have spinal cord injuries, where you'll see, like for example, there was one person I saw was like C7 and below, and so he still had C6, C5, C4, so he could move his shoulders, a little bit of elbow movement, but couldn't move his wrist, because wrist is now C7, T1, C7, C8, T1, I should say, right? And so you'll see that they can do certain things, right? Another patient, her injury was at C4, C5. To sign a check, she would actually put she puts the pen in her mouth and uses her neck muscles to sign it. How can she do that? What nerve is still working to move the neck muscles around? Because she has a pretty high
C2 and 3.
The deep
Yeah.
one.
What's the loop there that supplies all those neck muscles that allows her to do that?
Oh, start with an R.
There's an R in there.
Rafi something.
Ansa
Like-
cervicalis.
Oh, no.
Ansa cervicalis. So that was still working. Was that C1 to C3 or something like that?
Mm-hmm.
And so that's her injuries at C4, C5. So that's still working. Okay. So myotomes and dermatomes, and the last thing about that is that what confused me, and it may be confusing you, is the difference between the dermatomal maps and then the peripheral nerve maps. So if you look at the arm, you'll see some that has the, the lateral forearm nerve, and then you have other nerves all over the place, right? But then if you look at the dermatomal map, it's different. It shows the C5, C6, C7. What that's saying is that if you had a local injury to that local nerve, here's how it would present. But if you have an injury in the neck at that level, that's how it would present. And so that's why you need to know both, because if it looks like this peripheral nerve supplies this much, like in the leg. There's a certain peripheral nerve that supplies just the lateral thigh, and it can be impinged right by the ASIS. So if it has that pattern, it's probably happening there. But if it's wrapping around, it's probably happening back here. So if the problem's here and you're back there, you're in the wrong place. If the problem's here and you're over here, you're in the wrong place. And so these nerve distributions let you know where this is happening. Does that answer?
I'm still like, so I was trying to associate dermatome with like peripheral and like skin, and myotome more with the muscle, but don't do it
Yes,
like that?
that is
Or-
correct.
Okay.
Yeah, myotome is muscle function. Dermatome is skin sensation, yeah.
Okay.
But they're both segmental. Each level has its own dermatome and myotome.
Okay.
So there's a C2, there's a C3, C4, you can memorize all of that if you want. Okay, any other questions? All right, well, because eventually we need to make it into the central nervous system. We've been playing around the peripheral over here. We gotta make it in. So let's start with, or do you have anything you'd like to see? I could just do this for a couple hours, but if there's anything you want me to address, I can even write it on the side to make sure I get to it.
Did he go over the
Tracks.
tracks?
Yeah, maybe the tracks for sure.
He said
Okay.
he's focusing a lot on the tracks.
As it should be.
Mm.
Which tracks in particular?
Um,
All the ones in the spinal cord?
I think we did spinothalamic, corticospinal, corticobulbar, reticular,
Reticulospinal.
reticulospinal.
These are the three you need to know the most, especially for the spinal cord.
And then the ear one. He's obsessed with the ear one.
The ear one,
Yeah.
Which one's the ear one?
the vestibular, or
Yeah,
the?
yeah, yeah.
The cerebellum.
Yeah.
Oh.
I have notes too where I draw out a lot of these. Really, for the pathways, you have to draw them out. But with all this stuff, it's going to make more sense. But yeah, it's hard to do without drawing it. Okay, these are the three most important tracks in the spinal cord. If you know these, I'll tell you about that patient who signs the checks with her neck. She has something called Brown-Séquard lesion syndrome, where that one side of her body can feel everything fine, but it can't move. The other side of her body can move, but it can't feel anything. So it's weird. Motor is lost on one side, sensory is lost on the other. It's called Brown-Séquard syndrome. It happens a lot. It only makes sense if you understand the spinal cord and how it's wired. But once you understand how it's wired, it makes perfect sense. It's a really good, Brown-Séquard is a really good educational pathology because you have to know the wiring to understand it. And it was on the boards, I think a year ago. I remember one student telling me that because it was the class that I had taught neuro, and someone were like, oh, I didn't know Brown-Séquard is a big deal. And I'm like, really, Dr. Cloud made such a big deal out of it. How did you not think that? It's a lot of times, people with spinal cord injuries will get this. It's not always in its purest form. It's usually kind of like a little more vague, but we'll talk about that. Okay, we'll get there. Let's, first let's break up let's separate things. We have, this is what type, white or gray? Yeah, this is gray and this is white, right? So the white is, or the gray is what? Well, what's it made of?
Cell bodies.
Yeah, cell bodies. And the white is axons. Good. Now each one of these, when we get into the nervous system, remember how I said that muscles, you can see muscles, they're distinctly located. With these areas, there's no distinctions, there's no lines, there's no fascia. And so we need to label these, we still need to define these areas based on function. And so what we do is we assign them numbers. Laminae. Have you heard about laminae?
Mm-hmm.
Okay, go. There's only a few that you really need to know, I would say. When I'm studying, I don't use Roman numerals, because Roman numerals are hard to remember. So I studied numbers. It's easier to remember seeing a number than a bunch of dashes and maybe a B somewhere. Right? So I always convert things to numbers. Okay, I'm gonna give you the generalities. Keep in mind that sometimes there are, especially with neuro, it's not always clearly defined the same way in every text. And so Dr. E may use slightly different things, okay? But it should be too different, but always, of course, you're gonna listen to Dr. E. Okay, 2, this is your, not substantia nigra, substantia gelatinosa. Really big for pain modulation. Three and 4 are grouped together, although sometimes they will also include 5, maybe 6, but this is important for the spinothalamic pathway, yeah, it's gonna feed into that. 7, this is Clark's nucleus. I think proprioception, when I think of Clark's. I'm trying to give you general stuff. And then 9, this is where your alpha, well, and gamma, but alpha motor neurons, which are the ones involved with corticospinal. And then 10 sometimes is known just for the fact that it's around the central canal here. Central canal is one area where CSF is traveling up and down the spinal cord. Some of it's on the inside, some of it's surrounding it. Okay. Now for the, actually let's take a very short step back. Let's remember the horns. This is the dorsal horn. We have the ventral horn. And then sometimes we have a lateral horn. When do we have a lateral horn? Yeah, lateral horn is going to be T1 to L2. We'll also have a lateral horn. This is for sympathetic nervous system. we should probably talk about that as much as us naturopaths talk about the autonomic nervous system. We know it very poorly in general, and it's probably a good idea to know how that's structured and set up. Because then it keeps you from saying really weird stuff. There's one meme or something going around where they have it's like a chiropractor thing. It's got a picture of the spine, and then from each vertebrae, the first one's like eyes, ears, blah, blah, blah. Like, does C3 innervate the ears? Maybe the skin around the ears, but it's not providing auditory sensation. So if you understand things, there's so much, false information out there and garbage, and especially things that can make us look like fools when we spread it. So it's good to know the science and understand what you're doing, because you are a doctor here for 4 years or 5 years. Okay, anyway, so those are the horns. We also have the funiculi, dorsal funiculus, lateral funiculus, anterior funiculus. They're just big groups, just big categories. So sometimes they'll ask you big areas, are you in the Midwest or the Northwest or the Northeast? Or they'll ask, are you in this state or that city, right? But this is how I see it. I actually see these as like cities or zip codes, like when we get into the Brahmins area too. And, but you can have more general areas that are like the entire state or region. Okay, so now we covered laminae, horns, and funiculi. Now let's get into these three most important tracts. This is one. This is the dorsal column. This is another. This is the lateral corticospinal tract. And this is anterolateral tract, aka spinal line. Those are the most important. So by me telling you these are the most important, what am I trying to convey to you as far as you're studying or
Most clinically relevant.
know these inside and out. And then, if you want, you can get to some of the other ones. Keep it broad for the others, learn these specifically. Okay. We're getting kind of busy on here, so I'll probably have to swing over to there real quick. You have some others. So one thing is the anterior corticospinal. This is another tract, much less important, only about 10% of the fibers. Those fibers have not decussated yet, which I think is a little interesting. It's like a little detour. And we'll talk about this. We'll talk about this more because actually the fibers that will end up over here are actually traveling on the other side. And then they leave and go to the other side. We'll talk about that when we cover motor pathways. We had, someone mentioned reticulospinal. It's also kind of in this general area. Rubrospinal is somewhere over here. That's actually, I would consider rubrospinal and reticulospinal are the two really important assistant motor pathways. So this is like the professor, and then those are the two TAs, rubro and reticulo. Rubro does more flexion, reticular more extension. Generally. You have some other, you have other pathways, but the good thing about the pathways is most of them will tell you where they're starting from, where they're going to, and so based on the name itself and very little other information, you can deduce what it's doing and what its function is. All right, any questions? What time is it?
2:05.
2:05, all right. We passed 45 minutes. Is some of this making sense?
Yes.
Okay. Let's see, guys.
Can we do a 5-minute break?
Yes. Yeah, let's do a 5-minute break, people, and if you have questions, go ahead and ask me.
Thank you.